So we'll talk about a 45-year-old male who is getting chemotherapy for DLBCL, and after the fifth cycle presents with fever of 102 degrees Fahrenheit. The patient calls you basically and tells you that the patient is running fever of 102 degrees Fahrenheit. The patient has had a history of febrile neutropenia, COVID-19. So my question firstly to Dr. Sunil Chopade is, would you admit this patient right now? Tell the patient to come. Would you ask the patient to get a CBC done, inform you, or what would be your?
Myself, Dr. Sunil, as patient is on day 8 of R-CHOP chemotherapy. So there is a chance of neutropenia. I would like to call the patient to ER, would like to administer the first line antibiotic within an hour and send the emergency blood investigation or CBC. And as well as I would like to do a COVID testing for this patient. Maybe we can do a rapid antigen test for time being and wait for the results of in blood CBC and count.
Yeah, Dr. Ajay, any variation in your practice?
No, sir. I also preferably I'll ask, because it's a day 7, so I'll preferably give him advice to get admitted. At least if he's not very keen on admission, so at least I will ask him to follow up with the CBC to see whether it's a neutropenic fever.
No, so this is what is important. So whether you would ask the patient to get a CBC done, because the CBC turnaround time will be approximately around say 4 or 5 hours, or would you just directly tell the patient to take the first dose of antibiotics or call him to the hospital and tell him to get admitted? So what would you practically do?
Practical cell will definitely start antibiotics, will take culture, and preference will be to get him admitted.
All right. So I think we all know that with the antibiotics within 1 hour, they need to be administered if you are suspecting FN, and cultures and CBC is the one of the ways we have to investigate the patient. So yeah, admission is a reasonable thing. All right. The second question is, would you give a 45-year-old patient undergoing R-CHOP chemotherapy routine prophylaxis with PEG GCSF? Dr. Ravi Jaiswal.
Yes, sir. So, can you have the question again?
So he's a 45-year-old gentleman and he has had a history of febrile neutropenia in the first cycle. But supposing he was a normal 45-year-old person undergoing R-CHOP chemotherapy, would you give him PEG GCSF or GCSF routine prophylaxis? Dr. Smita, if not Dr. Ravi? Dr. Smita, ma'am?
Yes,
routine
Dr.
prophylaxis.
Rohit, for this 45-year-old male, I'll not use a primary GCSF prophylaxis. But in case there is an episode of febrile neutropenia in any of the chemotherapy, consider for secondary prophylaxis in the subsequent cycles.
All right. So if there was no history of FN in the first cycle, you would not have given pegylated GCSF in the fifth cycle. Okay. Any
but if it is an
disagreements?
elderly patient, depending on if more than 60,
yes, ma'am.
So then we are in the practice of using primary GCSF prophylaxis.
Yes, ma'am. Any variation in practice? Like anyone disagrees?
Hi, I'm Dr. Jaiswal.
Yeah. Yes. Hi. Tell me.
Yes. I'm sorry. My call got disconnected because I was sitting in an OPD.
Yes.
So,
tell me, sir.
The question is regarding routine prophylaxis?
Yeah, routine prophylaxis.
For R-CHOP chemotherapy?
Yes.
Yes. Absolutely, yes. I practice in Tier 2 city, and right now also I am sitting in a very peripheral OPD. So the most important fear that we have is we lose our patients of neutropenia and neutropenic sepsis. So I am actually very, very scared of febrile neutropenia in my day-to-day practice. And all my patients, absolutely all my patients on R-CHOP chemotherapy, they get prophylaxis.
All right. If Dr. Ajay and Dr. Sunil have anything to add to this, regarding their routine practice after RCHOP, whether they go for primary prophylaxis or secondary prophylaxis only.
So routinely, I don't use for primary prophylaxis. If someone lands up in a febrile neutropenia, then I will use GCS.
I also
All right.
uh, only if we face any febrile neutropenia episode, then only we add GCSA prophylaxis. Otherwise, routinely we don't prefer.
All right. But absolutely, the point which Dr. Ravi made, considering the resources and the testing capabilities also, I think that also somewhat increases the use of GCSF. We'll be maybe discussing about it later on also. Next slide, please.
I would like to add a point here for Dr. Ravi and others also, that if we are able to follow these patients, counsel these patients, and the patients are able to understand the importance of reporting as soon as the febrile neutropenia episode is there, and we have a mechanism of calling these patients if they don't come on the given date. So in that situation, I mean, it can be as a secondary, but in case you have limitations in doing counseling, follow-up, and you're not sure the patient will follow it, then maybe a primary prophylaxis.
Exactly. Thank you. The previous slide, please. Okay, so practical points we have discussed. Advise admission, CBC done and inform you not preferred because the antibiotics have to be administered in time. So supposing the patient has come to the casualty, Dr. Sunil, you have already sent a CBC and a blood culture. Would you also do a chest X-ray? Would you advise an HRCT? And would you test for COVID? 3 questions.
First, I would like to test for COVID. As of now, a patient has...
and Dr. Sunil, if you are testing for COVID, what test would you use?
So I will test with a rapid antigen test first, and also send maybe RT-PCR. Second thing, chest X-ray and HRCT, I won't do at this point of time, as patient is not symptomatic for breathlessness or cough.
Okay. So one small point in history, patient had mild cough and sore throat. Would you still not do an X-ray, or would you consider X-ray?
If patient has a complaint of cough, then maybe we can do X-ray.
All right. Dr. Ajay, 3 questions. Whether you would do a X-ray, CT, imaging, and would you test for COVID? So X-ray, yes, no, CT, yes, no, COVID, yes, no. And if yes for COVID, then what test? So Dr. Sunil wants to send a paired sample of PCR as well as antigen.
Sir, if CBC is showing very grade 3, grade 4 neutropenia, so I think I can only start antibiotics and may avoid COVID testing. But if in history he is giving clear-cut sore throat and cough history, then I may add COVID testing, and I will prefer RT-PCR rather than rapid antigen test. But at this point, I will not prefer any CT scan. X-ray I will may add if depending upon the upper respiratory tract symptom. But CT scan at this period I will not consider.
All right. First, Dr. Ravi, and then Dr. Smita. Dr. Ravi, what tests?
So, sir, I take this on my clinical examination. So I auscultate these patients, and if I feel any crepitation on auscultation, I go directly for HRCT if there is neutropenia. So that would pick up your COVID also, any pneumonia also, and that would help me in choosing my antibiotic wisely. So that's how I do it. If I feel that patient is sick, there is any hypotension, tachycardia, if there is crepitation on auscultation, I go directly for HRCT and COVID test.
And what about COVID?
Yes, sir, COVID also. Both COVID and HRCT.
Okay. No, in case you test for COVID, what would you use, you said? What test would you use?
For COVID, I do RT-PCR.
No rapid antigen.
No rapid antigen.
All right. Dr. Smita?
Yes, sir. I would do a X-ray based on respiratory symptoms, no HRCT, test for COVID with a rapid antigen.
All right.
Dr. Sefali and Dr. Neelam are also there on the panel.
Okay. I'm sorry, Dr. Shefali, I
available.
forgot. So, Dr. Shefali, your practice, this patient, what
Yeah,
would you do?
so I generally do not treat hematological malignancy. I do more with the GIGU and gynae, solid organ. But I mean, our practice here also, goes on the standard guidelines that if the patient is day 8 post chemotherapy and he's running fever 102, so we just call him to the emergency and assess him for whether he's at low risk, high risk, or intermediate risk, and then decide upon whether he will require any admission for that management, or for that matter decide on empiric antibiotics. If the patient has respiratory symptoms, we generally go for chest x-ray first, and based upon that and the severity of the respiratory symptoms, you may decide to go for HRC. COVID testing is a must if the respiratory symptoms are there.
All right, fair enough. So here I would like to ask Dr. Neelam regarding what is the current literature regarding false positivity of rapid antigen, and what is the current turnaround time of a PCR test? And is there any utility of rapid COVID test with home-based kit? So the patient is at home, you tell the patient to get himself or herself tested with using some home-based kit in the meantime till he or she reaches the OPD. What is your opinion on this?
Yeah, actually, three type of things are available. One is like antigen test we've been talking about. Another is PCR, which is more specific. But only thing is you need to pull the samples and then do it. There is another third possibility which is available, like a previous doctor was talking about the CARBA test. Same way, the same machine is there. Gene expert testing is there. See, with PCR, time constraint is there because you have to pull the samples, and invariably the results are available either same day evening or next day. With Gene Expert, it is almost like more specific, 99% specificity is there. With PCR, it is 75 to 80%. COVID, the antigen part, it is just 50% specific. If we do our antigen testing, we still need to confirm. If it is positive, it's positive, it is done. That's what is being seen. If it is negative, you will have to wait and get a PCR testing done. So best at present is get a Gene Expert testing done. Result is available within 1 hour, and specificity and sensitivity is around 90 to 99%.
All right.
Yeah.
So, but in the facilities who don't have the Gene Expert testing,
definitely they'll have to wait for PCR because it's more specific as compared to antigen. But still, if we want some early results, definitely you will have to combine the two things together. Antigen, okay, go for screening. If it comes out to be positive, that sorts out everything. But if it is negative, we'll have to go for PCR.
All right. And ma'am, your opinion about those rapid home tests? Because a lot of patients have been doing them at home without telling us also sometimes.
They are specific, okay. But positive is positive, but negative does not mean that it will not come out to be positive by PCR or Gene Expert.
But you feel they might have utility, especially in resource constrained settings or patients who take time to reach OPD hospital.
Not doing anything, and rather than waiting for the PCR results, at least 50% of the patients screening part, if it is there, they can be isolated and early management can be started. So that's the
so
thing.
Maybe they can be explained or counseled about their use when you are counseling about chemotherapy, something like that.
Yeah.
All right.
And you
All
need
right,
to wait till PCR results come. At least 50% are ruled out with this.
Okay, ma'am. Thank you. Next slide, please. So I'll start with Dr. Shefali. For this patient, the patient is having an ANC of 1000, fitting into definition of febrile neutropenia because there is a tendency for further drop in the next 1 to 2 days. What will be your antibiotic choice?
So again, this patient is running fever, and I presume that he's hemodynamically stable. ANC is above 1000. So I think the
patient is absolutely stable. And a related question is, ma'am, actually, like in other malignancies also, do you actually in practice use the mass score for febrile neutropenia, or you just assess in general?
Yeah, so it's not
antibiotics and mass score.
Yeah, so it's not a head-to-head. Actually, all scorings we do, but a general assessment, of course, if the patient is whether dehydrated, whether any respiratory symptoms or worsening of COPD, if the patient is having, and what is the severity of the symptoms what patient is carrying, and over and above all these things, I mean, any comorbid conditions, any organ dysfunction if patient is having. So these factors would decide me to make a choice for my antibiotics, whether to go on oral or IV, or patient would need a hospitalization for that matter. So if the patient is absolutely stable, no comorbid condition, and ANC 1000 tendency to fall ANC in another 2 days, I would prefer an oral antibiotic for him and not a hospital admission in this scenario. Yeah.
All right. So what would you use?
So the quinolones would be my first choice, maybe a levoflox, and depends upon if the patient has mucositis. I may, after examination, decide to add on the antifungal oral. Otherwise, if it's a mild mucositis grade 1, antifungals are not absolutely necessary. So it's the oral quinolones that would go for that fever.
All right, ma'am. Next, Dr. Smita, ma'am, what is your opinion? What would you use?
Sir, in this patient, we take it as 45-year young fit patients. As Madam has said, hemodynamically stable. We label it as low risk for now with all the organ functions normal, and start on oral antibiotic OPD basis with a plan to follow up in 24-48 hours. Either phone call, call in for review. If stable, continue same. If any new signs, symptoms, admit and escalate to IV antibiotic. So follow-up at 24-48 hours is very important if we decide on a OPD-based febrile neutropenia management.
All right. Dr. Ravi?
Sir, I agree with Shefali and Smita madam, but if there is anything on my auscultation or if anything on the X-ray or CT, I would not hesitate to put the patient on piperacillin tazobactam. So if I feel anything, there is even a 5% of doubt in my mind, this patient gets admitted and would get piperacillin tazobactam in my practice.
All right. Dr. Sunil?
So my preference for antibiotic of choice will be cefoperazone and aminoglycoside combination.
Both together at once? At this
At once, yes. Within 1 hour of admission, first dose of cefoperazone and aminoglycoside.
All right. So we have answers ranging from oral antibiotic, single IV antibiotic to a combo. Chal. Yes. Okay. So the next question is, okay. So if we don't have a dedicated place for isolating patients in casualty, then how do you manage them, considering that they may be having COVID infections? Dr. Ajay, any thoughts on this? Or whether all FN patients go to isolation chamber and you have doctors with PPE and all the other kits checking them in your hospital?
Sir, can you repeat the question?
So basically, this patient has a probability of having a COVID-19 infection, sore throat, fever, etc. in the pandemic. So does the emergency have a separate wing for such patients who have fever and who are on anti-cancer therapy, or they come in the common pool of patients? What is the route in your hospital?
So now, sir, at least at our place, we have a separate, means those who are suspected COVID.
Yeah, now it's much
with
better.
Symptoms suggestive of COVID. So we have in emergency also we have a separate beds for them, and if they will require longer, if they are unstable, so we have a facility to isolate them in a COVID observation bed. So in both locations we have, if patients are stable, we do COVID in emergency department in separate. In emergency also we have a separate beds for this suspected COVID patient. We do the COVID, and if they are stable, we counsel them to stay at home for isolation. And as per report, we again contact them what to do further. And if in emergency patient is not stable, so we don't send them home. We keep them in our isolation observation ward till the reports is available. So depending upon the situation, how stable is the patient in emergency department.
Yeah. So till now we have no COVID report. So this patient probably goes in an isolation sort of room if the facilities are available, which are not everywhere. Next slide, please. So there have been recommendations given by MAS regarding the management of patients. There is a big algorithm. The previous slide, please. With regards to OPD management, IPD management, isolation, etc. But just stop moving the slides. Just one slide previous, please. Yeah. But this patient basically was admitted to isolation. Antibiotic was started back, cefoperazone sulbactam, single agent. One of the reasons was that he was having history of febrile neutropenia. It was a fixed cycle of R-CHOP, curative setting, no risks. Would you start GCSF at ANC of 1000? He has received PEG GCSF, but now PEG ANC is 1000. So would you start initiate GCSF also along with your antibiotic? Dr. Smita.
Not at 1000. If you have previously used PEG GCSF, I would wait and follow up the reports.
Dr. Ravi. Yes, ma'am. Dr. Ravi.
I start.
All right. So now the patient's COVID-19 PCR report is positive. It has been received after 12 hours. Like Dr. Neelam also mentioned, the same evening you might get. So what next? Will the patient be shifted to a COVID bed? If the facilities of COVID bed are not available, would you shift the patient to a facility which has a COVID bed and advise admission? Or would you send him home for home-based care? The second question is, if CT has not been performed, now that the COVID report is positive, would you perform a CT? Now, again, coming to Dr. Sunil.
Yeah, so for this patient, if COVID is positive,
COVID is positive.
Still, I will follow up with CBC count if it is dropping, and if symptoms are increasing, fever is persistent, cough is increasing, then only I will do HRCT. As you said, the count is rising on the second day, it's 1200, and patient symptoms are only mild cough and sore throat. So I don't think HRCT is required at present.
All right. Dr. Ajay, would you shift to a COVID bed, admit the patient? If the COVID facility is not available, would you advise admission elsewhere, or would you discharge the patient home for home-based antibiotic like levofloxacin, which was mentioned, and isolation at home? And the second question regarding HRCT.
So, sir, again, it is depending upon the clinical scenario. Means we are already seeing
the clinical scenario.
CBC is clinical scenario. Patient is clinically well. So I think I will prefer to stay, ask him to home isolation. And anytime if I feel the patient is unstable, then definitely I will ask to do CT scan and get admitted.
Dr. Shefali?
Yeah, so our practice would be the same. If the patient is hemodynamically stable, like you told, and the counts next day showed 1200 with the mild sore throat only, I would prefer to send him home back with a whole, the COVID experts advice, and just make him follow up virtually actually. And the moment we feel that he is becoming unstabilized or the counts are getting low or any other complications is setting in, immediately call him to COVID emergency and get him admitted.
All right. I think Dr. Smita agree overall with Dr. Shefali, or any other point to make?
No, I do agree with her.
All right. Next slide, please. So this patient actually was admitted to a COVID bed in the same hospital. CBC after 48 hours showed 1200. The patient was running fever after 48 hours. Blood cultures did not show any growth. Here I would like Dr. Neelam to come in. If the facilities are available, would you send a respiratory biofire or something like that, considering that there are other viruses at play nowadays other than COVID also?
Yeah, when Delta wave was there, what we noticed that secondary infections are very common. So in case if the patient is running fever, he's still got some complications which we are thinking of. As the HRCT report is showing a score of 6, we usually don't expect, but otherwise we can send the sample for biofire and immediately it will give us a clue. If any other or any abnormal organism is present, any atypical bacteria, that can be detected early at this time.
All right, ma'am. To continue, CORAD score is 6. 48 hours, ANC 1200, increasing trend, but not completely normal. Do you escalate antibiotics, continue the same, and do you actually involve a pulmonary physician in such cases? Dr. Smita.
Yes, sir. We'll take an opinion from a pulmonary physician. And considering the counts are rising and the patient is stable, no worsening hemodynamic instability or worsening in the respiratory symptoms will not change the antibiotic. Would continue my first line antibiotic.
All right, ma'am. Dr. Ravi, any opinion on antibiotics? and pulmonary physician involved in such a case?
Yes, yes. Now I think by this time the pulmonologist gets involved. Even if the hospital has a infectious disease consultant, he also gets involved. And I think this situation is tricky. And if the patient there's any suspicion of hemodynamic instability, for me the most important thing is hypotension. If there's any hypotension, I escalate antibiotics like right and left. I don't care about what it is, because I have seen losing patients at this juncture. So I'd be actually very, very cautious at this time. Though I know that it may take for the viral fever to settle for some time, but yes, the entire team gets involved, and we need to be on our toes by this time.
Absolutely. Dr. Sunil, you started with aminoglycoside and cefoperazone sulbactam. 48 hours, fever is still there. ANC is 1200. Do you escalate? Do you add something? Or do you continue with your aminoglycoside and cefoperazone sulbactam?
So, no, at present, it looks like it's a COVID-related fever. I will continue with the first-line antibiotics.
All right. So, fair enough. Is there any opinion on specific COVID treatment in this patient? So would you start steroid? He has already received RCHOP. So obviously 100 mg prednisolone for 5 days he has already received. Would you start something else, antiviral or something like that, Dr. Smita? Or would you just do what the pulmonary physician or the ID specialist says? Like what has been your experience regarding COVID specific treatment in patients with febrile neutropenia?
So would go with the advice of the pulmonary physician, but whatever experience we have in management of these patients with COVID is, in case there are symptoms and requiring oxygen, the two specific agents we use are low molecular weight heparin and steroids. So follow up the patient in worsening signs and symptoms, irrespective of the HRCT finding, then use low molecular weight heparin and steroid plus minus antiviral based on the advice from we have the facility to request an opinion from pulmonary physician and infectious disease and continue the antibiotic till recovery of counts.
Okay, ma'am. Dr. Shefali, any opinion on this COVID specific treatment?
Yeah, I do agree. So if the patient requires any oxygen support or has a worsening respiratory symptoms or any radiological evidence of pneumonitis, which is COVID related, so we do really start him on at least steroid and low molecular weight heparin until the pulmonary physician or infectious disease specialist add on the treatment to that. And he is in the separate COVID facility.
Yeah, so overall I agree, but this patient was on RCHOP and presented at day 7, already has received 5 days of prednisolone. And we would be probably using DEXA if we are thinking of using steroid for COVID. So one of the issues is hyperglycemia and other things related to steroids also. So I know, a tricky situation. Dr. Ravi, any inputs on this? Dr. Ravi, is still there or not there? I think I'll move on. Next slide, please. So this patient was continued on the same antibiotic, the first line antibiotic. He subsequently became afebrile day 3, counts recovered, respiratory parameters throughout were normal. So what is your criteria for discharge? Coming back to Dr. Ajay, would you repeat a COVID test before sending him home? And what will be your criteria? So what all will you look at?
So, sir, he's already improving trend. So, at least I will not prefer to repeat the COVID testing. After day 10 or day 14, if patients remain stable, but as per guideline,
so he's just like maybe day 4, day 5. He's not day 10.
So immediately I will not require COVID testing while discharging, but before next OPD follow-up, I will ask to do a COVID testing just for prevention purpose, not to infect others. Otherwise, at discharge, I will not advise to repeat the COVID testing. But at day 10, day 14, when he is scheduled for next OPD follow-up, I may ask him to repeat the COVID and to follow up in OPD if negative.
All right. Dr. Sunil, any opinion on this?
Regarding the repeat COVID testing,
Criteria for discharge. So patient is stable, you will just send him home, or whether you would repeat a COVID test?
no, I won't repeat a COVID test. If patient is stable, I would send him home and advise the isolation for the required period for a week.
For a week. Would you ever repeat the test, like for follow-up or something like that, or would you just go ahead with the 6th cycle of RCHOP?
No, I wouldn't repeat this test. If next cycle is coming after 2-3 weeks and patient is clinically stable, I would go ahead with the next chemotherapy.
If Dr. Ravi is online again, opinions on this? If not, then Dr. Smita.
I agree with Dr. Sunil, sir. Will discharge now. Request for home isolation, not to repeat COVID at any point of time unless there are new signs symptoms.
All right. So the rituximab has been associated with increased COVID complications because of, I think, decreased cell immunity. And I personally have had 1 or 2 bad patients secondary to COVID and other things. And the patient was on RCHOP. And the second question in general is just experience sharing. This is the last question. Have you had any experience of COVID-related complications like mucor or colitis in febrile neutropenia patients? So I'll again start with Dr. Smita now.
Fortunately not, sir, not COVID-related mucormycosis. Some colitis we have seen, and mostly for leukemia on induction. At the peak of the first and second wave of COVID, we have seen COVID with leukemia on induction, ALL, ANL, and with different kinds of complication. Mucormycosis I have not come across related to COVID co-infection. Empirically, we use antifungal in leukemia inductions, empirically and therapeutically also, depending on the course of the febrile neutropenia.
All right. Dr. Shefali, any opinions on unusual complications or anything in the past 2 years with febrile neutropenia?
Yeah, so COVID-related, complications in febrile neutropenia patients, mostly the colitis related, as Dr. Smita pointed out, or at the most we have seen the pneumonitis, which is prolonging for long period. So otherwise, no mucor as such in solid organ I could remember in last 2 years or 3 years on COVID.
All right. Thank you. So I think I have come to the end of my discussion. Thanks a lot to everyone for a good discussion, and thanks to the organizers. I hand it back. Thank you.